Happy holidays from the Cardiothoracic section of the Academy of Online Radiology Education. My name is Dr. Scott Landreth from Oregon Health Science University, and we welcome you here at our blog. As always, I would like to start by thanking our senior editors, Dr. Christina Foos from Oregon Health Science University and Dr. Prasad Pant from the Mayo Clinic, without whom this blog would not be possible. In an article written from Cook County and Northwestern University hospitals, researchers described downfalls in the 30-pack year smoking model for lung cancer screening in the African American patient population. Between 2017 and 2019, 827 patients were referred for lung cancer screening, with 784 patients meeting smoking history criteria. Lung cancer screening was performed by USPTF and ACR best practice guidelines using low-dose computed tomography, and studies were read by board-certified radiologists who utilized the lung CT screening reporting and data system, hereafter referred to as LUNGRADS. LUNGRADS 1 and 2 results were considered negative exams, while 3 and 4 results were considered positives. These were then referred for multidisciplinary lung nodule clinic. Lesions were targeted for biopsy, and ultimately for treatment if needed. Still smokers were referred for smoking cessation. Enrolled patients self-reported their pack years smoked and packs smoked per day. 77.5% of patients were male, and 66.2% of patients identified as African American. The median study age of the patient population was 62 years. The median years smoked in the study was 40 years, with an interquartile range of 30 to 45 years. The median packs per day smoked was 1, and the median pack years smoked was 25 years. 75.5% of patients were still smokers, while 55% of patients reported smoking less than 30 pack years. It was noted that African American patients had the same number of pack years smoked, but had fewer pack years smoked compared to other groups due to a lower pack per day reported. In round 1 of lung cancer screening, roughly 94% of patients had a negative exam, while 5.7% received a LUNGRAD score of 3 or 4. The lung cancer incidence overall in the trial was noted to be 2.1% for patients with more than 30 pack years smoked, and 2% for patients with less than 30 pack years smoked. Subgroup analysis revealed the lung cancer screening incidence for African Americans was 2.5%. Although this was not significantly increased from their white counterparts, whose incidence was 1.9%, it should be noted that all of the African American patients diagnosed with lung cancer had reported less than 30 pack years smoked, which is significant. It should also be noted that there were no significant differences in cancer incidence between African American patients who had less than 30 pack years smoked and those with greater than 30 pack years smoked. During regression analysis, it was observed that female gender and co-diagnosis of COPD correlated with increased incidences of lung cancer. This study outlines nicely why lung cancer screening guidelines may need further inspection and updating. The Nelson trial, for which the current USPTF guidelines are based on, only had a 4% African American patient population enrolled in their trial. This study showed that African American patients report fewer pack years smoked than other populations, and that there is no appreciable differences in lung cancer incidence between African American patients who have greater than 30 pack years smoked and those who have less than 30 pack years smoked. Review of screening guidelines to include African American patients who had less than 30 pack years smoked may help identify patients who are disproportionately harmed by lung cancer. Of note, there is limited data on long-term mortality given the relatively short study interval follow-up period. This may be an interesting place for further research to focus on. This was also a relatively small sample size, and as such, small differences in study populations are not found to be significantly significant. Repeating the study on a larger scale may provide further detail and may increase the significance of the data observed. Thank you. Researchers from Massachusetts General Hospital analyzed the number of malignancies diagnosed on incidental lesions seen on low-dose CT scans for lung cancer screening and their associated costs. This study involved retrospective review of 7,414 scans for 4,160 patients to identify 3,165 scans for which the S modifier using the lung CT screening reporting and data system, hereafter referred to as LUNGRADS, was applied. Of these S modifiers, 303 of these scans had findings of extrapulmonary lesions. which were then whittled down to a final cohort of 229 scans in 225 patients with 241 total lesions. Those scans that were excluded were done so on the basis of being previously reported, of having a known malignancy, or those who were lost to follow-up. These 241 incidentally noted lesions were then worked up via standard protocols, and malignancy or benignity was determined by final tissue pathologic diagnosis. The lesions were stratified by location in 12 subcategories, including thyroid, kidney, adrenal, breast, mediastinum, intrathoracic lymph node, chest wall, including the axilla, liver, other upper abdominal, bone, esophagus, and pleura. Associated costs with the indeterminate lesions workup were estimated using the 2020 current procedural terminology codes and total facility relative value units, also known as RVUs, for each organ type. Out-of-pocket expenses were tracked via patient billing records. The mean patient age was 66.1 years, and the study was equally balanced by gender. Incidental lesions were most commonly found within the thyroid at 23.7%, kidney at 20.8%, adrenal gland at 10.8%, and breast at 10%. Final diagnosis of benignity was established in 207 of 241 patients after further follow-up. 20% of the 241 indeterminate lesions underwent further tissue sampling, which resulted in a malignant diagnosis in 20 lesions. True positives and false positives were calculated for each lesion and organ type, allowing for the estimation of an organ-specific positive predictive value and negative predictive value to be estimated. Costs associated with workup were obtained, and estimates were calculated per lesion and per patient. Extrapulmonary malignancy was detected in 20 of the 241 lesions for a prevalence of 8.9% in patients with incidentally noted indeterminate lesions and 0.5% of the general lung cancer screening population. The positive predictive value was highest for lesions within the chest wall and axilla at 36.4%, within the bones at 25%, and within the breast at 12.5%. The total cost of working up all indeterminate lesions was $26,320.52. The average cost per additional malignancy diagnosed was calculated at $1,360.03 per lesion. The extra cost per participant in the lung cancer screening comes out to $6.33 per participant. And there was $109.21 of excess cost per indeterminate lesion. 90% of patients had no out-of-pocket costs, while those that did have an out-of-pocket cost had an average cost of $160.60. In subsequent analysis, it was found that lesions in organs with low positive predictive values, such as the thyroid, had increased costs associated with the diagnosis of malignancy when compared to organs that exhibit higher positive predictive values, such as that of the bone subgroup. For example, the workup for a thyroid lesion to diagnose a malignancy cost $2,783.50 versus only $264.18 for a bone malignancy. The prevalence of extrapulmonary malignancy found incidentally in the lung cancer screening population mirrored that of the COSMOS trial, with a relative increase observed in the rate of incidence in the patient population with indeterminate lesions, which is 8.9% in this trial compared to 6.2% in the COSMOS trial. This was explained by studies being read entirely by thoracic-trained radiologists and improved iterative reconstructive techniques that are now available, increasing thoracic radiologists' sensitivity and specificity. The added cost per patient at $6.33 and the cost per indeterminate lesion of $109.21 are quite low for the added benefit of catching early treatable malignancy. While the low negative predictive value observed in certain organ systems and complete lack of malignancy identified in other entire organ systems raise important questions over what should be done when incidental lesions are detected in these organs. This is a suggested area of further research. Thank you.
Hello, my name is Dr. Andrew Steubenrock from the Oshner Medical Center, and I'll be talking about a few more articles that are from the recent cardiovascular literature. Our first article is titled Dual Energy CT Pulmonary Angiography Quantifies Vasculopathy in Severe COVID-19 Pneumonia. This was from a recent issue of Cardiothoracic Imaging. Researchers from the Royal Brompton Hospital in London, UK, sought to investigate the utility of dual energy CT pulmonary angiography to evaluate the influence of COVID-19 and the virus's role on disease duration, right ventricular dysfunction, lung compliance, the D-dimer value, and obstruction index. The quantitative value investigated with dual energy CT was relative perfused blood volume, which was defined as pulmonary blood volume divided by pulmonary arterial enhancement. The researchers generated an automated color scale using the enhancement patterns seen on the dual energy, and perfusion defects were determined qualitatively by observing segmental hypoenhancement using this color scale. The study included 27 ventilated patients who underwent scans, dual energy scans to diagnose pulmonary thrombus, with 11 surveillance patients who were scanned roughly 2 weeks later. To reduce beam hardening artifact, if the BMI was greater than 35 or they were not able to position their arms correctly, they were excluded from the study. Images were acquired using bolus tracking within the pulmonary artery of a trigger with 120 Hounsfield units. Each voxel was derived from a 3-material decomposition algorithm for air, soft tissue, and iodine, and this was reconstructed using a dense lung pulmonary blood volume map with a Hounsfield unit threshold of under 200 or minus 200. What the researchers evaluated the images for was the morphology of a perfusion defect. Was it wedge-shaped, mottled, or amorphous? The presence of thrombus within the pulmonary artery, and order of involvement along the pulmonary artery tree to see if there's an anatomical correlation between perfusion defect and pulmonary embolism. The control participants used for this study were obtained from examinations from a prior case control study at the same facility. As far as results go, filling defects consistent with pulmonary embolism were seen in 11 of 27 patients, with a similar distribution through each order of the pulmonary arterial tree, and that includes the main branches as well as lobar and segmental. Visually scored perfusion defects were seen in all dual energy CTPA studies, with the amorphous pattern of defect becoming the most prominent. That was seen in 21 to 27 cases. However, the predominant pattern of amorphous defect was only attributed to pulmonary embolism in 2 of the 27 cases. Relative perfused blood volume in COVID-19 patients was shown to be significantly decreased when compared to healthy controls, as expected, and they found that right ventricular dysfunction diagnosed by echocardiography was present in nearly all cases. However, was not shown to be related to differences in pulmonary arterial enhancement. They did see an inverse relationship with the relative perfused volume and right ventricular dysfunction when controlling for age, gender, BMI, and ethnicity. When comparing symptom onset to timing of the initial dual energy CT, there's no statistical correlation to average perfusion defect and duration of disease, but when the study was obtained less than 14 days from the onset, visually scored perfusion defects were greater than after 14 days. Overall, the results show that in patients with COVID-19 respiratory failure, there's reduced pulmonary relative perfused blood volume as expected, and that over time, this improves, suggesting that pulmonary angiography may reflect an acute feature of severe COVID-19 pneumonia. And this is an imaging finding that could potentially be useful as an important marker and surveillance tool during the duration of the COVID-19 pandemic period. There are multiple limitations with this study. There's a small cohort size. Participants all came from a single center, and a single scanner was used for all acquisitions. And pathology assumptions were made without imaging without histological proof, although it would seem a bit excessive to do biopsies in this patient population. Additional studies are needed to compare the findings of respiratory failure due to COVID in comparison to other pulmonary infections, which could lead to respiratory failure. Our next article is titled Evaluation of a Tube Voltage Tailored Contrast Medium Injection Protocol for Coronary CT Angiography, Results from the Prospective VOLCANIC Study. Researchers from the Medical University of South Carolina sought to investigate the feasibility of commercially available software to determine if tube-tailored contrast medium dosage would be useful in reducing contrast load and radiation dose. 120 patients were selected for the study and were evenly divided amongst 7 groups with increasing kV values ranging from 70 to 130 and corresponding contrast doses ranging from 33 milliliters to 65 milliliters. Scans were obtained prospectively with ECG-triggered adaptive sequential mode acquisition using Siemens CT scanners. Readers with 2 to 4 years of cardiovascular imaging experience rated the study subjectively on a scale of 1 to 5, 1 being the worst, 5 being the best, in regards to contrast enhancement, image noise, and overall image quality. Hounsfield attenuation was measured in the aorta, main pulmonary artery, left main and right coronary arteries, as well as the left anterior descending and left circumflex coronary arteries. Results show that contrast attenuation in the arteries peaked in the 70 kV group, while it was lowest in the 110 and 130 kV groups. No significant differences were observed in the signal-to-noise ratio and in contrast-to-noise ratio between the kV cohorts. The 70 kV group was shown to have a contrast-to-noise ratio figure of merit significantly different from the remaining 2 voltages. CNR-FOM, which is the contrast-to-noise figure of merit ratio, is a calculated value obtained from dividing the square of the contrast-to-noise ratio by the radiation effective dose, and it was meant to more effectively compare the different groups of kV values. Overall image quality was rated as diagnostic across all 2 voltages by the specialized readers. Overall, the results show that dedicated software is able to determine patient-specific contrast media administration to reduce overall total contrast dose and radiation dose. Specifically, lower doses such as 70 kV could be used for study acquisition without decreasing subjective or objective image quality. Like all studies, there are limitations to this one. This study only investigated image quality and did not attempt to evaluate the effect of the 2 voltage difference on pathology such as coronary artery stenosis. Software used to select the 2 voltages is only available from a single vendor, and thus broad market acceptance would be difficult. And finally, the acquisition groups do not have all the same amount of patients included, which could have affected the representation of certain voltages. Our final article is titled In Situ Pulmonary Artery Thrombosis, an Unrecognized Complication of Radiation Therapy. This is from the American Journal of Radiology. Researchers from MD Anderson Cancer Center evaluated the role of radiation therapy with in situ pulmonary artery thrombosis. Cardiovascular complications are the leading cause of non-cancer related morbidity and mortality in patients who undergo radiation therapy, which included accelerated coronary artery atherosclerosis, valvular sclerosis, myocardial disease, pericardial disease, conduction disease, and autonomic diseases. In situ pulmonary artery thrombosis is defined as when a thrombus develops in the pulmonary artery and not a migration from a deep vein source. 27 patients were determined to have radiation therapy-induced in situ thrombus as by retrospective analysis of the imaging database. Patients were excluded if thrombus is deemed to be tumor thrombus or stump thrombus following a lobectomy and/or pneumonectomy. Multiple variables were examined, including was it central versus eccentric thrombus, which segment of the pulmonary artery was involved, occlusive versus non-occlusive, angle of the thrombus to the vessel wall. And they also evaluated if there was presence of lung fibrosis, right heart strain, and the relationship of the thrombus to radiation therapy and over time. Review of the imaging showed that radiation therapy-induced thrombus was more common to be a single non-occlusive eccentric thrombus with an obtuse angle in relation to the vessel wall. Thrombi were exclusively located within the pulmonary vasculature affected by the radiation changes, and there was no single artery location, either main, lobar, or segmental, that showed a predilection to formation, and that the affected vessel was based solely on where the radiation-induced fibrosis had occurred. This study is important in developing the literature regarding radiation therapy-induced in situ pulmonary artery thrombosis, as the clinical and treatment implications of this condition are unknown. Further review of follow-up CT examinations for the study did not show embolization to the ipsilateral or contralateral lung on follow-up imaging, and this could play an important role in determining if anticoagulation is needed with this condition. But I think the biggest consideration for this study is that radiologists actually just know that this entity can occur and be able to distinguish it from an acute PE. This study is a good initial start. However, every study has limitations. It has a small study size, and a larger patient study population could have different results. Additionally, there is a lack of pathologic confirmation to the imaging findings. Further, larger powered studies are needed to determine the differences between acute pulmonary thromboembolism, thromboembolism, and radiation-induced in situ pulmonary artery thrombosis. Thank you for listening, and looking forward to seeing you in a couple months for our next edition.
And as always, thank you again for tuning in to the cardiothoracic section of the Academy of Online Radiology Education.